Hi, I'm Anne Woolfield.
I'm Mel Akerman.
And I'm Carla Pecoraro, and we're your hosts of the Uterine Sound podcast, bringing you up-to-date information in all things O&G. Today, we're covering a very important topic, ectopic pregnancy. Hemorrhage from ectopic pregnancy is still the leading cause of maternal mortality in the first trimester, so it's important to be aware of how it presents and what we should do about it. I'm sure you've heard us harp on about this enough already, but ectopic pregnancy should be at the top of your list of differential diagnoses when a woman of reproductive age presents with pain and bleeding. So what exactly is an ectopic pregnancy?
An ectopic pregnancy occurs when a fertilized egg implants outside of the endometrial cavity. Most commonly, the zygote implants in the fallopian tube. However, it can actually implant anywhere. Other sites for an ectopic pregnancy include the cornua, the ovary, the cervix, or a previous cesarean scar. There's even such thing as an abdominal pregnancy where the zygote implants in the abdominal peritoneum or even over an organ like the bowel or liver. This week, we'll focus our discussion on the more common tubal ectopic pregnancy. We'll go into some of the rare and more complex types of ectopic next week. So how common is ectopic pregnancy?
An ectopic pregnancy occurs in 1 to 2% of all pregnancies, and as Mel said, 97% of these are located in the fallopian tube. Rare types of ectopic pregnancy occur much less frequently at a rate of 1 in 1,000 for each type of pregnancy. Those crazy abdominal pregnancies are by far the rarest, and they occur in 1 in 10,000 to 1 in 30,000 pregnancies. To understand which patients might be at risk of an ectopic pregnancy, it's firstly important to understand how an ectopic pregnancy occurs.
Ectopic pregnancy is thought to occur because of abnormal motility in the fallopian tube. In a normal pregnancy, the egg is released from the ovary and becomes fertilized by the sperm within the fallopian tube. The fertilized egg is then transported to the endometrial cavity through the action of smooth muscle contraction and beating cilia, where it implants in the endometrium. With an ectopic pregnancy, this process is disrupted. Tubal obstruction or damage to the microscopic cilia within the fallopian tube can impede the tube's ability to guide that fertilized egg into the uterine cavity. As a result, the pregnancy implants somewhere it shouldn't, like the fallopian tube. There's typically enough blood supply in these regions to allow the pregnancy to progress to a certain extent, but clearly the room for the ectopic to expand is limited. As the ectopic grows, it distends the fallopian tube and eventually leads to rupture, which can lead to excessive hemorrhage and even maternal death if the patient isn't treated urgently. So clearly we can see how damage to the fallopian tube can lead to an ectopic pregnancy. But how does that damage occur?
Damage to the fallopian tube can occur through anatomical disruption or functional disruption. Previous surgeries, infection, and inflammation can lead to blockage of the tube. Altered cilia function can also occur through exposure to toxins and hormonal changes. Thinking about the pathophysiology can help us to identify risk factors for ectopic pregnancy. Previous ectopic pregnancy, tubal surgery, tubal pathology, and previous genital infection all increase the risk of ectopic through physical damage to the fallopian tube. Smoking and infection directly affect the way the cilia in the fallopian tube function, and actually, so do hormonal variations in the menstrual cycle. Chlamydia infection especially has been shown to increase the release of a cytokine known as interleukin-1, which actually encourages the pregnancy to implant into the fallopian tube. Interestingly, IUD use also increases the risk of ectopic pregnancy. Now, with the IUD, it's important to note that contraception actually reduces the overall risk of ectopic by reducing the overall chance of pregnancy. However, if you did happen to fall pregnant with an IUD in situ, there is a higher chance of that pregnancy being ectopic, up to 50%. I find this concept can catch people out sometimes, especially in multiple choice questions. Other risk factors include infertility, assisted reproductive technology, advanced maternal age, and recurrent vaginal douching. There's also a higher chance of ectopic in women who conceive on other contraceptives, such as the combined contraceptive pill. Women with sterilization failure also have a higher rate of ectopic. So now that we know a little bit of the background information, let's talk about how an ectopic pregnancy might present.
Most women with ectopic pregnancies will present with bleeding, abdominal pain, and a positive pregnancy test. Symptoms typically present from about 5 weeks gestation when the tube is distended enough to cause pain. Most symptomatic women are stable with mild lower abdominal tenderness and normal observations. Rupture occurs in 18% of ectopic pregnancies. Patients with a ruptured ectopic usually present with a sudden onset of severe pain, which is typically suprapubic or localized to the lip or riff. In severe cases, the pain might be felt in the upper or middle abdomen, or even at the shoulder tip if the blood reaches the diaphragm. Abdominal peritonism and cervical motion tenderness are typically suggestive of rupture, as is hypovolemic shock. Remember, young women compensate extremely well until they don't. So if there's any signs of hemodynamic instability, you should really take care and consider it to be a sign of large volume hemorrhage. A bedside fast scan can often be used to identify hemoperitoneum in unstable patients. A small subset of patients will be asymptomatic and have an ectopic pregnancy detected incidentally on an early dating scan or after follow-up for pregnancy of unknown location. Let's talk investigations.
When working up a patient with a suspected ectopic pregnancy, you should do a full blood count, a group and hold, urea and electrolytes, LFTs, and obviously a serum beta-HCG and a transvaginal ultrasound. The reason we do urea and electrolytes is because we're looking for any pre-existing renal or liver injury that might be a contraindication to methotrexate, which, as we'll learn soon, is the only medical treatment option for ectopic pregnancy. We do often associate a suboptimally rising beta-HCG with an ectopic pregnancy, although it's important to note that some ectopics will have a normal beta-HCG doubling time. It's also important to note that ectopic pregnancies can rupture at any beta-HCG level, even if the beta-HCG has been falling.
So I wanted to talk about this a little bit more. I think the concept of a beta-HCG doubling time can sometimes be a little bit misleading. A better way to describe it would be the beta-HCG rise, which is often measured over 48 hours. Around 85% of normal intrauterine pregnancies will have a beta-HCG rise of at least 66% every 48 hours. Although what can be considered a normal beta-HCG rise actually depends on the beta-HCG level. With a beta-HCG under 1500, a normal rise can be as low as 49% in 48 hours. With a beta-HCG between 1500 and 2000, a normal rise can be as low as 40%. And with a beta-HCG between 3000 and 10,000, a normal HCG rise can even be as low as 33% in 48 hours. For these reasons, relying on a suboptimally rising beta-HCG alone to make the diagnosis of ectopic pregnancy can be dangerous. There is always a possibility that a normal intrauterine pregnancy may be present, even when the beta-HCG is not doubling over 48 hours.
I also just wanted to say that when you're doing serial beta-HCGs, it's important that the patient gets them done at the same lab. There are some variations in the assays and reporting methods used, and so when we're comparing beta-HCGs, we want to minimize that as much as possible. So we mentioned before how we wouldn't expect to see an intrauterine pregnancy on transvaginal ultrasound until a beta-HCG hits 2000. Why is it that we can see an ectopic pregnancy at much lower levels of beta-HCG?
With an intrauterine pregnancy, what we're looking for is a gestational sac with a yolk sac. And as you've rightly said, this often can't be seen until the beta-HCG is 2000 on transvaginal scan or 5000 on transabdominal scan. With an ectopic pregnancy, we don't need to be able to see a gestational sac in order to diagnose an ectopic. I mean, it's definitely helpful if you can see a gestational sac with a yolk sac or embryo, but it's not always necessary. What we often see instead is a heterogeneous mass in the adnexa. This is the most common ultrasound finding and is present in about 89% of cases. Now, this mass is typically made up of some pregnancy tissue, which may or may not include a visible gestational sac, as well as surrounding hemorrhage and edema. Because the pregnancy is located in the tube, it doesn't need to be very far along before it starts to cause trouble and a visible mass on ultrasound. An ectopic pregnancy also produces far less beta-HCG than a normal intrauterine pregnancy. For this reason, we tend to be able to see an ectopic pregnancy at a much lower beta-HCG than an intrauterine pregnancy. So then what about those cases where the beta-HCG is above 2000, but we still can't see an intrauterine pregnancy on ultrasound? Can we diagnose an ectopic then?
Not necessarily, but it would definitely be higher up on my differential diagnoses list. So what we're talking about here is the beta-HCG discriminatory zone. The discriminatory zone is the serum beta-HCG level above which a gestational sac should be visualized when an intrauterine pregnancy is present. Now, there is actually no universal consensus on what this beta-HCG level should be. In Australia, we usually consider this level to be 2,000 for a transvaginal scan, but only 2 years ago, we actually considered that level to be 1,500. So what we really need to know is how accurate these levels are, especially if we're considering treating a patient with methotrexate without a visible pregnancy. When the beta-HCG is 1,500, about 80% of intrauterine pregnancies will be visualized. And when the beta-HCG is 2,000, 91% of intrauterine pregnancies will be visualized. This means that 9% of perfectly normal intrauterine pregnancies will have a beta-HCG of 2,000, but no pregnancy is seen on scan. Some organisations, like UpToDate, suggest using a beta-HCG of 3,510 as the discriminatory zone. But even then, at this level, 1% of intrauterine pregnancies will still not be visible on transvaginal scan. If the patient is obese, has fibroids or adenomyosis, she has an increased risk of ultrasound failing to detect an early intrauterine pregnancy when the beta-HCG ranges from 1,500 to 3,000. The other thing to consider is multiple pregnancy. In multiple pregnancy, the serum HCG level will be higher than expected for a singleton pregnancy, and yet you still might not see an intrauterine pregnancy on scan. Levels of over 9,000 have even been described for intrauterine triplet pregnancies unobserved by a scan.
So interesting. I think it's still important that if you have a patient with a beta-HCG of more than 2,000 and no visible intrauterine pregnancy on transvaginal scan, you should still consider the possibility of an ectopic and make sure the patient gets appropriate follow-up.
Absolutely. Nothing stresses me more than when I see a patient with a beta-HCG over 2,000 and nothing visible on scan without a good follow-up plan. All right, so let's move on to management of ectopic pregnancy. Let's say we've got a clearly visible ectopic pregnancy on ultrasound. What are our treatment options now?
Well, the management of an ectopic pregnancy really depends on the stability of the patient as well as her preferences. Options include expectant management, medical management, and surgical management. Surgical management is the first-line management option for women who present with a ruptured ectopic pregnancy. In these patients, expectant and medical management are not suitable and can be very unsafe. Women in significant pain, with signs and symptoms of rupture or hemodynamic instability, should all undergo urgent laparoscopic removal of the ectopic pregnancy. Surgery is also the preferred management option when the beta-HCG is greater than 5,000, if the adnexal mass is greater than 35 millimeters or has a fetal heart rate, or if the patient is unable to return for follow-up with expectant or medical management. Stable patients can generally select from expectant medical or surgical management options. A woman might choose surgical management if she values a treatment that is of shorter duration with less follow-up, and if she's willing to take the risks and recovery time associated with surgery. Typically, surgery should only be performed if a transvaginal ultrasound clearly shows a tubal ectopic or an adnexal mass suggestive of an ectopic pregnancy. If there's no mass visualized on scan, there's a high likelihood that a tubal pregnancy will not be visualized or palpated at surgery, thus resulting in an unnecessary laparoscopy.
So what actually happens with surgery? Do we always have to remove the fallopian tube?
The two surgical options for management of a tubal ectopic pregnancy include a salpingectomy and salpingostomy. A salpingectomy refers to removing the fallopian tube, whereas a salpingostomy involves making an incision in the tube, removing the ectopic, and leaving the tube in situ. A salpingectomy is a standard procedure if the tube with the ectopic pregnancy is damaged, bleeding is uncontrolled, or the gestation appears too large to remove with salpingostomy. It's also the recommended procedure if the other tube appears to be healthy. This is because the reduction in fertility with removing the tube compared to keeping it are similar, and also with salpingectomy there is less risk of persistent trophoblastic tissue or recurrent ectopic pregnancy. One study compared salpingectomy to salpingostomy and found that fertility rates were actually similar between the two groups. Most people think that fertility is reduced by 50% when you remove one tube, but actually fallopian tubes are clever and also quite mobile. So when an egg is released from the other ovary, the remaining fallopian tube is able to move towards the egg and pick it up. Consequently, the reduction in fertility is only about 15%. Leaving the fallopian tube behind is also associated with an increased risk of recurrent ectopic. The theory is that the fallopian tube containing the ectopic is already damaged, which is why the pregnancy occurred in the first place. When you leave that damaged tube behind, the patient has an increased risk of developing another ectopic pregnancy in the same tube.
Salpingostomy is typically offered if there is damage to the contralateral tube, either known blockage or previous salpingectomy. This procedure is much less commonly performed. Women who undergo salpingostomy instead of salpingectomy still need to have serial beta-HCG follow-up until negative to ensure resolution of all trophoblastic tissue. There is a higher risk of persistent trophoblast, meaning that some pregnancy tissue may be left behind and can subsequently continue to grow. As a result, patients with salpingostomy have a 20% chance of needing further treatment such as a salpingectomy or methotrexate. In patients with contraindications to methotrexate, a salpingectomy should therefore always be performed instead of a salpingostomy. With salpingectomy, once the histopathology has confirmed an ectopic pregnancy, there is no need for ongoing beta-HCG follow-up. The patient is typically advised to do urine beta-HCG at 3 weeks at home and to notify the hospital if it remains positive.
Okay, so next we move into expectant management. This option is usually only advised for patients with a beta-HCG less than 1500 that is declining and an adnexal mass less than 35 millimeters with no fetal heart rate. The patient should have no pain, be hemodynamically stable with no evidence of rupture, and should also be located close to the hospital and able to attend for follow-up. Patients undergoing expectant management have serial beta-HCGs performed every 48 hours for 8 days. If the fall in HCG is greater than 15%, then the beta-HCG can be repeated weekly until it's negative. If at any point the HCG is not falling or the patient develops any symptoms, then an ultrasound should be arranged. As we said before, ectopic pregnancies can rupture at any beta-HCG, even if it's falling. And so patients undergoing expectant management should be advised to present urgently if there's any abdominal pain, bleeding, or any other signs suggestive of rupture. The benefit of expectant management is that some ectopic pregnancies will resolve without any medication or surgery. This allows the patient to keep both of her fallopian tubes, to avoid surgery, and to avoid the side effects of any medication. The downside is that this option requires prolonged follow-up, close proximity to a hospital in case rupture occurs, and the possibility that the ectopic pregnancy could rupture at any time. It's also important to consider avoiding any pregnancy until sonographic resolution of the mass, noting that this can actually take a really long time, much longer than it takes the beta-HCG to go back to zero. Some studies suggest that the presence of retained resolving trophoblastic tissue within the fallopian tube could increase the risk of recurrent ectopic and advise women to avoid trying for another pregnancy for 3 months, since 95% of tubal ectopic pregnancies should resolve by then. They even suggest that a follow-up scan could be offered to women at that time to identify those who should wait longer.
The final management option is medical management, which is done with methotrexate. This option is suitable for patients with a beta-HCG up to 5,000, with an adnexal mass of less than 35 millimeters and ideally no fetal heart rate. As with expectant management, patients should have no significant pain, be hemodynamically stable, and have no evidence of ruptured ectopic. The patient should be able to attend for prolonged follow-up and again should be in close proximity to a hospital. They should be fully informed of methotrexate and its side effects and consider it to be an acceptable option. Methotrexate can actually be used at any beta-HCG level, although it's much more likely to be successful if the beta-HCG is under 5,000. Oh, and you need to make sure there's no IUP on ultrasound.
Ooh, the old heterotopic pregnancy. How often does that happen?
Well, the literature quotes an incidence of heterotopic pregnancy to be about 1 in 30,000. But I've been involved in about 8 cases so far, and I have definitely not seen 210,000 patients. I think a new epidemiology study is definitely warranted. The incidence of heterotopic pregnancy is definitely increasing with the use of assisted reproductive technology, and in these patients has been reported to be as high as 1 in 500. For those who have no idea what we're talking about, a heterotopic pregnancy is when a patient has an ectopic pregnancy and an intrauterine pregnancy. In these situations, methotrexate absolutely needs to be avoided, and surgery tends to be the only option if the ectopic is progressing. Methotrexate is teratogenic to intrauterine pregnancies, and so surgical management of the ectopic pregnancy can allow removal of the ectopic while allowing the intrauterine pregnancy to progress unharmed. It's also really important to note that although it is rare, heterotopic pregnancy is always a possibility in any ectopic pregnancy. For this reason, we recommend not instrumenting the uterus at the time of laparoscopic removal of ectopic pregnancy. We have all heard about cases where the uterus was instrumented at the time of surgery for the ectopic, only for it to be discovered a week or so later that there is also an intrauterine pregnancy. Our primary responsibility is to first do no harm, and so keeping those instruments out of the uterus is paramount.
Medical management is typically done by IM or IV methotrexate. Sometimes it can be injected directly into the ectopic pregnancy. Methotrexate is a folic acid antagonist. It inactivates dihydrofolate reductase, causing depletion of tetrahydrofolate, which is necessary for DNA synthesis. As a result, it inhibits cell proliferation in fast-growing tissues such as the trophoblast. Because methotrexate is used as a one-off dose, side effects are rare, but it is important that the woman is fully informed about them. Common side effects include conjunctivitis, mouth ulcers, and dizziness. More rare side effects include myelosuppression, neurotoxicity, hepatotoxicity, nephrotoxicity, pulmonary toxicity, alopecia, mucositis, and a sensitivity to sunlight.
I know we've just rattled off a lot of scary side effects, but I think it's important to note that in the majority of patients, they tend to just get a bit of nausea and sun sensitivity. I think the worst thing I've ever seen is some transiently elevated liver function tests that return to normal within a week or two.
Yeah, it sounds scary, but these side effects are much more relevant to people who are on this medication in the long term. Methotrexate is actually a chemotherapy drug, so it's used in the treatment of some cancers, like choriocarcinoma, for example. But it's also used daily in women with rheumatoid arthritis or severe psoriasis. Women who are on this medication long term are more likely to get these kinds of side effects than someone taking it as a once-off dose for treatment of ectopic pregnancy.
Although, because of the possible impact of methotrexate on these organs, it's important that we screen for contraindications before administering the medication. Women with chronic liver disease, renal dysfunction, pulmonary disease, peptic ulcer disease, pre-existing blood dyscrasias, or a known sensitivity to methotrexate should avoid the drug. Because it is teratogenic, women who are breastfeeding or who have a coexisting intrauterine pregnancy are also not suitable to take it. Breastfeeding should be considered a precaution for methotrexate. Women should be advised to express and discard their breast milk for 4 days after a single dose of methotrexate for an ectopic pregnancy.
The dose of methotrexate is 50 milligrams per meter squared administered IM to a maximum dose of 100 milligrams in patients with normal renal function. It's important to note that this dosage is based on body surface area rather than weight, which is a bit of a weird way to dose a drug. Do we know why it's this way?
No.
Okay then. The IV dose, the IV dose, on the other hand, is 100 milligrams stat followed by 200 milligrams over 12 hours. Another important thing to consider for IV dosing is that you need to check the urinary pH, and you give sodium citrotartrate to ensure the pH remains over 7. Now, how do we know whether a patient needs methotrexate IM or IV?
IM methotrexate is preferred if the beta-HCG is less than 3,000, the mass is under 3.5 centimetres, and there's no fetal heart rate. If the beta-HCG is greater than 3,000, the tubal mass is over 3.5 centimetres, or there is a fetal heart rate, then IV methotrexate is preferred. IV methotrexate is also preferred over intramuscular for the atypical ectopic pregnancies, which we'll go into next week.
Follow-up includes a beta-HCG on day 1, day 4, and day 7. If the beta-HCG drops by more than 15% between day 4 and day 7, then it should be repeated weekly until negative. If the beta-HCG doesn't drop by more than 15%, then a repeat transvaginal ultrasound should be performed to exclude rupture and the presence of a fetal heart rate, and a second dose should be administered. About 15% of patients will require a second dose of methotrexate, and less than 1% of patients will need more than 2 doses.
Why do we do the beta-HCG on day 4? I always get phone calls from people who are worried because the beta-HCG on day 4 has risen. Isn't it supposed to do that?
Good question. It is normal for the beta-HCG to rise between day 1 and day 4, so we are not really worried if this does happen. This is due to continued HCG production by syncytiotrophoblast despite cessation of production by the cytotrophoblast. After day 7, the HCG should be repeated weekly. If the HCG drops less than 15% from day 7 to 14, then a third dose of methotrexate is administered. If the HCG drops more than 15% from day 7 to 14, then the HCG should be performed weekly until negative. It usually takes about 35 days post-methotrexate to become negative, but some patients have slow clearance of serum HCG, and it can take as long as 109 days to become undetectable. The maximum number of doses of methotrexate is 3.
Women who choose medical management of ectopic pregnancy should be advised to avoid pregnancy for a minimum of 3 months. Methotrexate is teratogenic and has a really long half-life. Therefore, contraception should be offered until this 3-month period has been completed. The toxicology literature actually recommends a 4 to 6 month washout period before attempting to become pregnant. However, a study of patients who conceived after ectopic pregnancy showed that the rates of fetal malformation were not increased in those who conceived within 6 months of methotrexate versus those who conceived after. Even if a patient does conceive within 3 months of methotrexate, the pregnancy should be allowed to continue. There is no evidence of teratogenic risk to those who conceive sooner. All patients trying to conceive should take folate daily. Women should also avoid intercourse and pelvic examinations during surveillance of methotrexate therapy or expectant management, as these can increase the risk of tubal rupture.
It's also important to avoid alcohol and folate-containing vitamins. The whole point of methotrexate is to inhibit folic acid, and so if you then go and administer folic acid, then you're theoretically reducing the efficacy of methotrexate. Sun exposure should be avoided to limit the risk of methotrexate dermatitis. Women should also wear sunscreen. The methotrexate does not have any long-term impact on the woman's ovarian reserve. As for expectant management, women should be informed that there is still a risk of ectopic pregnancy rupture whilst the pregnancy is resolving. This is about 10%. Women should be advised of the signs and symptoms of rupture and to present urgently to the hospital if they experience any of these symptoms. In particular, pelvic examinations and intercourse can carry a risk of rupture in the acute phase of medical management of ectopic, and this should be avoided.
Now, with methotrexate, mild to moderate abdominal pain lasting 1 to 2 days about a week after receiving the methotrexate is common. This is usually due to tubal abortion or tubal distension from a hematoma and can be controlled with paracetamol. Severe abdominal pain, however, is concerning for tubal rupture, so if the patient is unsure, they should present for review.
Now, I know we've just said to avoid folate supplements if we've given IM methotrexate. What about IV methotrexate?
So IV methotrexate is a completely different kettle of fish. When we give IV methotrexate, there is a higher chance of those nasty side effects that we spoke about earlier. Folinic acid is given in conjunction with IV methotrexate in order to counteract the toxic effects of high-dose methotrexate. Folinic acid is typically started 24 hours after starting methotrexate. It is preferentially picked up by normal cells and allows them to produce tetrahydrofolate, essentially reducing the adverse effects of methotrexate and protecting normal cells from the medication. The regimen for folinic acid is quite confusing and needs to be given at certain times, so we always recommend consulting your local guideline for instructions on how to dose this.
Is there anything that reduces the success rate of methotrexate?
So the success rate of methotrexate for ectopic pregnancy is about 90%. This can be reduced by high serum HCG concentrations, the presence of a fetal heart rate, a large ectopic size over 3.5 centimeters, and the presence of peritoneal fluid. A high serum HCG is the most important factor associated with methotrexate treatment failure. Patients with a beta HCG of more than 5,000 are more likely to require multiple courses of methotrexate or experience treatment failure. The presence of fetal cardiac activity is another relative contraindication to medical treatment. Ultrasound evidence of fetal cardiac activity is significantly associated with treatment failure. A larger ectopic size can also increase the chance of failed medical management. Most studies on methotrexate use for ectopic pregnancy have actually been in patients where the ectopic mass is less than 3 to 4 centimeters. And even in these studies, it does show a slightly lower success rate of 90% when the mass is 3.5 to 4 centimeters, compared to 93% when the mass is under 3.5 centimeters. The presence of free fluid in the pouch of Douglas is controversial. While it has been associated with higher failure rates, there's not really a consensus on the volume of peritoneal fluid that's more likely to cause a problem.
So, we said before that methotrexate is also a chemotherapy agent. Our nursing staff usually take cytotoxic precautions when administering the medication. Are there any special precautions the patient needs to be aware of after being given methotrexate?
Methotrexate is excreted by the kidneys, so you should flush the toilet twice and avoid contact with body wastes for 48 hours. Avoid alcohol and folic acid containing vitamins for 48 hours. Avoid gas-producing foods like a high FODMAP, things like leeks, onions, cabbage, beans for the first 2 to 3 days, as this may worsen abdominal pain. And watch out for transient abdominal pain within the first week. Simple analgesia should be enough. If you faint or need anything stronger than Panadol or ibuprofen, then return to the hospital as there is a risk of rupture. Avoid intercourse for a minimum of 2 weeks. There is no evidence of long-term side effects, future pregnancy losses, or future congenital abnormalities with methotrexate therapy.
So that summarises our 3 main management options: expectant management, medical management with methotrexate, and surgical management with salpingectomy or salpingostomy. What other things should we take into consideration when managing a patient with ectopic pregnancy?
If the woman is rhesus negative, anti-D is recommended at the time of surgery or methotrexate administration or at the decision for expectant management. Because of the association of ectopics with STIs, every woman with an ectopic should have an STI screen and be treated if positive. Smoking cessation should be encouraged in order to reduce the risk of ectopic in future pregnancies. A discussion on contraception is warranted if the woman is not trying to conceive, or if she needs to undergo follow-up for expectant or medical management of the ectopic. The patient should be advised that fertility is reduced by about 15% with medical and surgical management if the contralateral tube is normal. It's also important to note that we can only assess the tube macroscopically, and microscopic abnormalities cannot be detected. The risk of recurrence with an ectopic pregnancy is 15% after 1, 30% after 2. We therefore recommend an early pregnancy localization scan at around 6 to 7 weeks in the next pregnancy to check for another ectopic. Patients should also be advised to present to ED in the event of pain or bleeding in a subsequent early pregnancy because of that increased risk of ectopic.
I think it's also really important to remember that this woman and her partner have suffered a pregnancy loss and to recognise that. People often get caught up in the diagnosis and management of ectopic pregnancy and forget that this experience can be just as upsetting as a miscarriage. Support the woman with her bereavement, offer her condolences, and refer her on to bereavement support services such as SANS and Beyond Blue, or advise her to listen to the Glimmer podcast, which is really helpful for women who are experiencing pregnancy loss.
Oh, and don't forget to chase the histopathology. We want to confirm that the ectopic has been removed and we haven't accidentally taken the wrong tube.
Okay, time for a final recap. Ectopic pregnancy refers to implantation of a pregnancy outside of the endometrial cavity. It occurs in 1 to 2% of pregnancies, and 97% of those ectopics will occur within the fallopian tube. Risk factors include sterilization, tubal surgery, infection, a previous ectopic, smoking, and falling pregnant with a marina in situ.
Most women with ectopic pregnancy will present with pain, bleeding, and a positive pregnancy test. About 18% will experience rupture and may present with peritonism, hemodynamic instability, and free fluid on scan. A minority of patients have their ectopic identified incidentally on ultrasound scan.
Management options include expectant, medical, and surgical. Expectant management is only appropriate if the beta-HCG is 1500 or less and is falling. The mass is less than 35 millimeters and the patient has no evidence of rupture. It involves serial beta-HCG until negative. Surgical management is typically by a laparoscopic salpingectomy, although salpingostomy is possible in the event of a damaged second tube. Women having a salpingostomy need serial beta-HCGs due to the risk of persistent trophoblastic tissue and have a 20% chance of needing further treatment like methotrexate or surgery. And medical management includes methotrexate administered either IM or IV.
Methotrexate is a folic acid antagonist and targets rapidly dividing cells. Side effects include nausea, gastrointestinal side effects, stomatitis, and sun sensitivity. More rare side effects can include most organs such as the kidneys, lungs, liver, bowel, and bone marrow. Patients undergoing methotrexate have a day 4 and day 7 beta-HCG aiming for a drop of greater than 15%.
Women receiving methotrexate should be advised to avoid pregnancy for at least 3 months. They should avoid folic acid and alcohol and should flush the toilet twice. Pelvic exams and intercourse can increase the risk of rupture and should be avoided in the early phase.
Don't forget anti-D for rhesus-negative women and to offer bereavement support. There is a 15% chance of recurrent ectopic pregnancy, and so you need an early dating scan next pregnancy. Women should also be screened for and treated for STIs and advised to quit smoking.
Thanks for listening to this week's episode of the Uterine Sound podcast. As usual, you can find our summary slides on Instagram later in the week. Follow us on socials on Instagram and Facebook at The Uterine Sound, or check out our website www.theuterinesound.com. You can also email us at theuterinesound@gmail.com.